So I'm going to give a community perspective in 7 minutes or left with 21 slides. So hold on. And then we'll have a panel discussion. So just think about questions and just kind of what's the different perspectives, and they're all valid, right? And so I think this will be an interesting discussion. Okay. So blips are contentious. So U equals U, big thing. We love U equals U. It's a very good message. And a lot of people use it as their prevention thing. So this is a slide from NHS, which is looking at blips going from detectable to undetectable. They don't define what the line is for that detectable, undetectable is, which is kind of one of the issues around it. So an occasional blip doesn't mean your HIV treatment is failing. They happen, as we've seen from the labs, it's a common thing. But when they repeat, is there a difference between a blip versus a failure? So are we getting repeated blips happening? And so there is something happening, and there could be some genetic resistance happening. So that's what we're kind of looking at. But the question is, what is that line? So an occasional blip, not a big deal, because most people go back down. So when you look at Terence Higgins, they're looking at 200 in terms of their measure. They're seeing some blips in this line. They're all below the 200 range. They're in the 50 to 100 kind of thing. And they're all kind of in that space. According to U equals U, anything under 200, no risk of transmission. So that's good. When we look at the WHO, they brought out a policy brief around of viral suppression. And they did a systematic review. So this is the thing that came out by Bill and Melinda Gates looked at all the different studies and the different transmission events, and under 200 there was zero cases of transmission in those studies across 24 countries with 7,762 people. When they looked above that to 1,000, there was 2 cases of transmission, but there was long intervals between when the viral load was taken and when the transmission occurred, so 50 days. So did that play into it? So that's the piece that kind of drove their recommendation. So they came out with a recommendation last year, which looks like this. So you have unsuppressed, you have suppressed but detectable, and you have undetectable. So this is where they came with the U equals U statement last year. WHO took a really long time to come on board with U equals U. So their thing, they came out and they said suppressed is detected but less than 1,000 copies per ml, almost zero or negligible risk of transmission to sexual partners if you're under 1,000. So that's what WHO says. But then they said undetectable, not detected, zero risk, was according to the test. So as you've seen with the machines, they all have different values. So I don't like that statement, but the under 1,000 is negligible risk, almost zero in terms of that measure. And that's mainly for third world because their viral load testing isn't that great. So this made U equals U available in Africa. So that, we'll come back to that. In a hurry because I've got to go. We have so many slides. So in terms of transmission risk, your transmission risk, most people are the green on ART, undetectable. That's the 95. We're trying to get everybody to that. Their risk of transmission in the right-hand pillar is up the top. You can't even see it because it's so minimal because they're undetectable. Yellow's ART suppressed. Again, there's a small risk of transmission. Most of your transmission is coming from people who are undiagnosed because their viral load is up 30,000, 40,000 copies, right? Not 2,000. So up to 500,000 copies. So that's kind of where most of your transmission is coming from. It's undiagnosed or not on treatment. So this is we've already covered that. So in terms of all the different machines out there, there's that fancy one called Panther. They can all measure different lower levels of detection, 90, 70, 500, 200. The big thing for us is at 200 copies per ml. That's what U equals U is kind of using as zero risk. So anything under 200 we determine is U equals U. Zero risk of transmission. That's what Terence Higgins says. Everybody says that. So in terms of the language, and that's become a huge campaign, right? We have it on T-shirts, on lanyards, on posters, and people use that as their badge of protection. Like, I am undetectable, there is zero risk of me transmitting it. So that's what I take on board, and that's what I use in my conversations and as part of my identity, right? So, we do it at pride parades. We have all these campaigns around the world. It's gone everywhere, and it's a huge game changer in terms of stigma and self-worth, right? So this is a statement from Burnett Foundation. So being undetectable became a part of my life, my identity, when talking about my HIV with my whānau, my partners, my friends, like, it's a big thing. So you can imagine it came as quite a shock when I had a phone call from my doctor who informed me that my viral load was no longer undetectable, right? So it's detectable, but what's the number, right? So that's the important thing, is how do we communicate this thing? So AIDS-Map and a few other people have come out and said giving a viral load below 200 is harmful because it stresses people out, right? I'm now no longer detectable, I'm potentially infectious, should I be having sex with my partner? That's what it says to them, right? So, and that's the perils of overly sensitive viral load testing. It's really great, it's getting better, more accurate, more consistent, but it's getting to the point where it stresses people out if they get a blip, right? Especially if you blip to 25, right? I've gone from 20 to 25, and I'm getting told I'm detectable. If I don't know anything, that's gonna freak me out. So, the other issue is Health New Zealand's going with this whole digital health record. So I won't even get this from a doctor. I'll look it up in my health record and it'll say my viral load is 28 copies. I won't have a doctor to explain it to me. I will freak out. How do we manage that? That's the potential. That's where we're moving towards. So one of the recommendations that came out from the AIDS-Map thing is we do counseling, education, inform people. Rather than just saying U equals U, we reinforce that 200 copies per ml so people understand what it means, so they don't freak out if they see a 25 or a 50. And the other thing we could do, is we could change the lab form. So it adds a comment, because we have reference ranges on values and things like that. What's a normal reference range? Could we add a reference range statement if your viral load's under 200? We add a comment saying no risk of sexual transmissions for viral load less than 200. You've got a viral load of 52, which is fine. So the person's informed, like, I need to be conscious about what I'm doing, am I taking care of myself? But I'm still undetectable as far as research, and there's no risk of transmission. So that way it makes it, you're part of the conversation, you're informed, you're getting the data, so you're part of that piece as well. But how do we get that other message across, the education piece? So coming back to this, that's why I have a problem with this, detectable, undetectable, but it doesn't say what that line is. It needs to have a number. It should say 200, and that's from NIH. The other thing, just so you know, is when we talk about 95, 95, 95, the way WHO defines that is virally suppressed is for people that are less than 1,000 copies per ml. So that's what that 95, that virally suppressed in terms of the 95, that's what they're kind of looking for. That's the way it's designed, and it's still almost zero negligible risk of transmission. So, yeah. So we've seen all that. So that's the statement around 200. But what about 1,000? So like 200, I think is fairly backed up by science and everything like that. WHO has gone to 1,000 copies per ml. So should we be having statements on reports or education around if you've blipped to 500 copies, what does that mean? As now am I a risk? According to WHO, you have almost zero or negligible risk of transmission at that point. So in terms of that individual test, right? So one thing is an individual test, but if you get a blip, you should repeat and make sure it's not viral failure, right? Is it repeating, or is it just a blip because you took a vaccine, or you're anxious, or was it did they use a PPT instead of an EPTA tube? So you repeat to see if there's actually something happening. But if it's under 1,000, like it's reason for concern, but it's not a reason to say, okay, you can't have sex with your partner anymore, you need to use condoms. Because that's the way people will take it on board, right? So my message with this is we need to have really good adherence for people, because being undetectable is important. That's how we stay U equals U. But we need to have really good communication, and we have really good trust with our doctors. So if they tell me, like it's okay to tell me that you're 35 copies per ml, that's okay. But you need to explain it so I'm part on that journey with you, right? And so then I can look at what I've been doing that might have been bad. Maybe I've been adjusting my doses or missing, or maybe doing some other things that might have affected. I can reconsider my situation and change my behavior to do better. I think that's kind of the message we get across. So I think, yeah, and then this is just around blips versus resistance. These are all the things that could factor into it. Maybe I couldn't get access to my meds, maybe there's stockouts. There's all those kinds of things that could play into this situation that could affect my adherence. So yeah, that's my piece.